let's just bypass the pleasantries today and drop right into a high-stakes 270-plus level simulation. In this explainer, we're covering the exact mechanisms and clinical traps of gastrointestinal pathology. Look, if you're gearing up for the wards or an advanced board assessment, you already know GI pathologies are heavily tested. Why? Because of their overlapping presentations and their terrifying potential for rapid, life-threatening escalation. Our goal here is simple. Make sure you never fall for the classic distractors.
Section 1. IBD and the transmural divide. Let's get into it.
Right off the bat, notice how the underlying tissue architecture completely dictates the disease course. You really have to continuously contrast the deep, full-thickness, discontinuous inflammation of Crohn's disease against that superficial, retrograde spread we see in ulcerative colitis. Because Crohn's inflammation is transmural, it penetrates literally all the mucosal layers, and that is exactly what allows for the formation of fistulas and strictures. UC, on the other hand, it's strictly confined to the mucosal and submucosal layers, always starting in the rectum and moving proximally without skipping a single segment. Now, let's isolate the highest yield extraintestinal targets. Take a close look here. Ulcerative colitis is strictly linked to primary sclerosing cholangitis. On the flip side, the transmural nature of Crohn's uniquely drives fistula formation. We're talking enterocutaneous or colovesical fistulas. Plus, because Crohn's heavily targets the terminal ileum, you get this profound fat malabsorption that strongly predisposes these patients to calcium oxalate nephrolithiasis and gallstones. Truly understanding these structural baseline differences is what prevents you from just guessing when you're faced with secondary complications on a vignette.
Moving on to Section 2. The acute megacolon catastrophe.
So let's detail this absolute catastrophe, which is predominantly seen in ulcerative colitis. What's actually happening here is that the intense mucosal inflammation breaches its usual boundaries, right? It heavily infiltrates the smooth muscle layer of the colon. The result is total paralysis of the colon and massive dilation. To actually diagnose this, you need radiographic evidence of colonic dilation greater than 6 centimeters, combined with clear, undeniable signs of systemic toxicity. Think of fever over 100.4, profound tachycardia, a white count over 10,500, or hypotension. Make no mistake, this isn't just a severe stomachache. This is a shock state waiting to happen. Let's check out this clinical variance box to pinpoint a very specific high-yield trap. During a severe UC flare, a patient is going to experience frequent, bloody diarrhea and cramping. But, and this is absolutely crucial, if you see an abrupt cessation of diarrhea in that exact same patient, do not assume they're getting better. That sudden halt, especially when you see massive abdominal distension and hemodynamic instability, signals the onset of massive colonic paralysis. The bowel has literally just stopped moving. Building on our management protocols, you absolutely must recognize these strict pharmacologic contraindications here. While 5-ASA compounds like mesalamine are totally standard for managing an IBD flare, during an acute toxic megacolon event, they are strictly contraindicated. The exact same goes for anticholinergics and opioids. Any agent that further reduces colonic motility is going to severely aggravate the underlying smooth muscle paralysis. That dramatically increases the risk of an explosive colonic perforation. You just have to step back and let the bowel rest. All right, Section 3, ischemic and diverticular traps. When a patient comes in with acute colonic distress, context is everything. You have to contrast the vascular insufficiency of ischemic colitis with the infectious, toxin-driven pseudomembranous pathology of C. diff. Ischemic colitis usually shows up in older patients with cardiovascular risk factors. It triggers severe pain right after meals, what we call intestinal angina. Imaging might show bowel wall edema, classically known as thumbprinting, and a scope would reveal pale mucosa with petechial bleeding. C. diff, however, is driven by recent antibiotic exposure or a hospital stay. It presents with massive leukocytosis, often shooting above 20,000, and those classic yellowish pseudomembranes. Now I want to highlight a highly discrete management step for another really common acute presentation, diverticulitis. Guys, this is a non-negotiable rule. Acute diverticulitis mandates CT imaging to confirm the diagnosis and rule out complications like abscesses. Performing an acute endoscopic evaluation like a colonoscopy or sigmoidoscopy is an absolute contraindication. That inflamed, weakened diverticular wall is basically a sitting duck for iatrogenic perforation. Don't do it. Section 4. Colorectal neoplasia and surveillance. Let's analyze this classic radiographic finding. What you're seeing is an apple core lesion on a barium enema. It perfectly visualizes a circumferential colonic neoplasm that's narrowing the lumen. Note how the location completely dictates the clinical presentation here.
Right-sided colon cancers typically bleed very slowly, presenting insidiously with fatigue and occult iron deficiency anemia. Why? Because the ascending colon has a much larger caliber, and the stool there is still liquid. Left-sided lesions, like the one we're looking at, produce obstructive symptoms, crampy pain, and an altered, narrowed stool caliber, because the descending colon is narrower and the stool is already solid. Because colorectal cancer develops in a very predictable stepwise fashion from adenomas, we rely on strict surveillance intervals based on precise histologic grading and size. If a scope is totally normal or just shows hyperplastic polyps, you wait 10 years. Easy. If you find 1 to 3 small tubular adenomas, that interval drops to 5 years. But if you see high-risk features, meaning adenomas with actual dysplasia, anything over 10 millimeters, or a heavy burden of 5 to 10 tubular adenomas, you absolutely must repeat that colonoscopy in exactly 3 years to stop the progression to adenocarcinoma.
Okay, moving to section 5, the integrated assessment. Let's pull this all together. Let's break down this third-order vignette. We've got a 28-year-old male with a known history of ulcerative colitis. He's spiking a fever of 103 degrees, his heart rate is 128 beats per minute, and critically, he has acute abdominal distension with a sudden shift from his typical bloody diarrhea to absolutely no bowel movements at all. So, what is the most appropriate next step in management? Well, you should immediately recognize this as the textbook hallmark of an acute megacolon catastrophe. He has clear systemic toxicity and the physical signs of profound colonic dilation. Take a look at these 5 options. This matrix is specifically engineered to test your strict adherence to the procedural contraindications we just talked about. Lock in your answer in your head before we break it down. All right, let's exhaustively rule out the incorrect options by applying exact pharmacology and physiology. Option A, the colonoscopy, that poses a catastrophic risk of perforation in a paper-thin, dilated colon. No way. Option B, 5-ASA compounds, as we established earlier, are totally contraindicated during an acute flare of this severity. Option D, lopromide, is an antidiarrheal. That's just going to rapidly worsen the smooth muscle paralysis. Option E, CT angiography, is a brilliant test for acute mesenteric ischemia, but it's not the right modality for a UC complication. Which leaves us with option C. It is strictly correct. A plain abdominal X-ray is the safest, fastest initial test required to definitively confirm a colonic dilation greater than 6 centimeters. As you go forward and manage acute colonic emergencies, I want you to continually ask yourself, how does the underlying transmural or mucosal architecture permanently dictate a patient's lifelong surgical risk? Really consider how these distinct pathologic baselines alter literally every subsequent clinical decision you will ever make. A superficial mucosal disease like ulcerative colitis might risk toxic megacolon today, but technically it can be cured by a total colectomy. A transmural disease like Crohn's, however, is going to follow that patient throughout their entire GI tract, permanently dictating a lifelong risk of strictures, fistulas, and complex surgeries. If you master the baseline architecture, the clinical presentation will always make perfect sense.